Welcome to Raising the Bar, the podcast that pulls back the curtain on the country's most successful leaders and how they elevate their business and their teams. Please welcome our host, Alison DePauli.
Welcome to the next edition of Raising the Bar live, although it's not live today, it's been pre-recorded. It is my pleasure to introduce you to Isaac Higgins, the Director of Operations and Technology at Family Hospital System, which is a remarkable institution. My original goal here today was to talk about how Isaac purchases healthcare for his employees as a business owner and with what he knows about healthcare. But we have just had the most thoughtful conversation about the evolution of healthcare and what he thinks that means for employers. So we're going to talk about that first. So Isaac, thank you for joining me today.
Allison, thank you for having me.
So we just had such a great conversation about cash pay pricing and how you see basically PPO networks, and we'll not pick on anyone in particular, evolving themselves out of business. And you have a different reason for thinking that than most people do.
It's a very unique perspective just because coming from a family-owned business called Family Hospital Systems, my father was an ER physician of 20 plus years, got really fed up with healthcare as a whole and was tired of running the medical mill. Being an ER doctor, seeing 50, 60 patients a shift, working in a level 1 trauma center, he was kind of burnt out at that time. When we moved to Austin back in 2011, he came across a new industry at the time called freestanding emergency rooms. Him and a couple of partners got together, poured all their life savings into it, and were finally able to operate medicine the way that they saw fit. Through all of that, they had to become insurance experts.
I'm sure they did.
Learning how claims and how the insurance companies don't sometimes want to pay everything that they need to pay and push a lot of that responsibility back onto the patient. So kind of evolving out of that one facility, they grew it to about 6 in the North Austin location or North Austin area and kind of expanded out of emergency medicine into more of a general acute hospitals, offering things outside of emergency care such as imaging, labs, primary care, even surgical services, and a very special substance abuse program that we operate inside the hospital. Through all of that, it's been really interesting trying to work with large insurance carriers. You know, people—
That's a good word.
Yeah. Interesting. Very interesting, right? You think it would be as easy as going to a large insurance carrier and saying, hey, we want to be part of your network. We think we do good care. That is not how it goes.
No, it's not.
If we were to, for example, sign some of the contracts we were proposed, we'd be running out of business in a couple of months. And when you start really looking at the Consolidations Appropriations Act, right, with all the price transparency and everything else that came about, you start recognizing that, wait, a lot of those large hospital systems are getting far more reimbursement than us, just the little guy. So how can we actually kind of expose some of this truth and start really showing people what the true price is of healthcare? We are so excited for the cash era.
I know you are.
We are blasting our prices everywhere we can because we know what the other guys are getting paid, and we're asking far less than what the average MRI reimbursement is by Medicare. Right? It's almost laughable that we weren't allowed to go in network and we were treated as these evil out-of-network facilities driving the cost of healthcare so high.
It is amazing to me. I have a client and it's lab related, which is a little different than imaging, although we all have our stories about imaging, who's had routine lab work and sent it to the lab company, and the lab the lab company billed the plan $498 and billed the wrong TPA, sent my client to collection. So my client is obviously very upset. When the whole thing got settled, the plan paid $98 for the $498 of lab work, and the cash price was $80. And this gentleman, he's a lovely man, just could not get his head around this and was completely and utterly outraged. But that's the same for imaging. It's the same for outpatient procedures. It's the same for hospital stays. I mean, we've had some conversations about what it costs to be operated on in your facility.
Absolutely.
And it is a truly reasonable price.
And people don't really understand when you use insurance, there's more costs passed on to the provider and everyone else in the middle that, the insurance price is always going to be more than the cash price. Because I have a billing company I have to pay a percentage to. I have another 2 or 3 full-time employees that I'm using to track down all of the AR, accounts receivable, from these insurance companies, and keeping track of everything. There's a hidden cost.
It's not so hidden. It's a lot of bodies in an office that do not practice medicine. They practice billing. And I'm not sure they like it either.
They do not. I think there's a era of cash coming our way from providers that are tired of submitting insurance claims, spending 30, 40 minutes of charting on each patient that is dictated by the insurance company on how they're supposed to chart in order to get paid. It's like every obstacle they just put in front of these providers is driving them closer to the cash model. You have so many providers, especially in primary care, that have broken free from insurance altogether, right? The rise of direct primary care, which is a monthly subscription model to your local provider, has grown greatly just here in Austin.
And San Antonio too, and continues to scale at a remarkable pace.
And people can't believe that they can pay $60, $70, $80 a month and have unlimited access to their healthcare provider.
Yes. And for more than 5 minutes at a time.
Right. It's a remarkable, because people, and I think I speak kind of broadly here, but people are scared to go to the healthcare provider for a lot of different reasons. One, it's big one in my mind, is the financial aspects.
Absolutely.
I'm already paying, especially if I'm a family, upwards of $1,000 a month sometimes.
Easily.
For a $2,000-$3,000 individual deductible.
$7,000 deductible.
I'm being conservative.
Yes, you are.
But at the end of the day, I don't want to have to pay another $60 plus meet my deductible to go see a provider that could or could not give me a right answer about something, right, with my illness. So I think there's a financial aspect that is keeping people away from healthcare, and the availability of direct primary care just kind of alleviates a lot of that financial burden. I
have a dear friend who is a widow for just a few years now, so not too long. And she had a medical issue that certainly wasn't life-threatening, but required medical attention. And she'd gone to the emergency room and was advised by her emergency room physician that she said, "You need to see your doctor tomorrow." She called her doctor. This was at the end of April. They could see her in July. And I was doing a LinkedIn Live with a mutual friend of ours who is a DPC doctor and is a remarkably calm, nice, settling presence, as many doctors are. And she called me crying. "I don't want to die. This is what happened to Richard. He got shoved from provider to provider. And this is terrible. And I don't want this to happen to me. And I have this thing and I can't see my doctor till July. And I just want to see Dr. So-and-so." And I said, "Okay, we'll deal with the rest later." I said, "But I can fix the first problem." And I could fix the first problem. But what if I'm a regular everyday person and I don't know somebody to fix that problem for me? Right? It's not good for the humans.
No, it's not. And I was spoiled growing up.
In the house.
My dad wasn't a doctor. If I got sick, I didn't go to the doctor. I said, Hey, Dad, I got strep throat again. Can you write me amoxicillin? Thank you.
Yes.
So I never really knew the lack of access that people had to healthcare. And it's amazing when you talk to some people, they haven't seen a doctor of any kind.
In years.
A decade. And I'm like, I don't know, but if I was you, I would go get some like basic blood work done just to get some basic labs and just figure out where everything is, because who knows, you're walking around fine today, tomorrow you could have a stent placed in your heart.
That's no joke. My father, he's watching, he's going to kill me, but that's okay. He had renal cell carcinoma about a decade ago. It was discovered because his now primary care physician, he decided he wasn't sick. He wasn't going to the doctor. He didn't go to the doctor for like 5 years. And he got a letter from this doctor saying, "If we don't see you by the end of the year, we're going to assume you're not our patient. And I'm not renewing my admitting privileges in the local hospital. To which we looked at him and said, please go see him because you're going to get a hospitalist if something happens to you. And there's nothing wrong with a hospitalist, but they don't know who you are.
Right.
He went and he had renal cell carcinoma. The thing was this big. It weighed 10 pounds.
Oh my gosh. Okay.
I mean, like, that's not uncommon. Don't go to doctor, find a serious thing. And he's fine, right? He's fine. But what if he didn't go back to the doctor? I mean, it's a problem when people don't get basic medical care.
Absolutely. Or just the access to it.
Access to it. You know, they don't know if it's, especially people on a high deductible plan. I mean, I understand, you know, the purpose of a high deductible health plan was to help a person be a good consumer, except there are no tools for them to be a good consumer. Now we have some tools, and they get better all the time,
right? Including
Family Hospital posting their pricing, which is remarkable to people. What do you mean the price? Well, it's the price.
$50 for an x-ray? Yeah, that sounds good.
Yeah. $450 for a CT?
Sounds good.
Okay. That works. You mean it doesn't cost $2,500? No, it does not.
No, it does not. And if you force us to use your insurance,
it's going to.
It's going to, because if you got another hour and a half, I can sit here and explain to you the entire process behind the scenes.
Well, you could give us the abridged version.
As a consumer, though, let's be honest, you spend maybe 30 to 60 minutes a year really evaluating your health insurance plan.
On a good day.
On a good day, right? And usually you have a broker and a couple of HR meetings that are telling you what's coming out that year. Beyond that, how often are you checking into the latest trends in healthcare?
You're not.
Unless you're you and I,
well, of course.
we're in the industry looking at every little thing coming up that's new. Like you said, all the tools that are coming out, fantastic.
Yep.
But to your average consumer, they just want to know, where can I go? How much is it going to cost? And are they going to take good care of me? Educating the consumer on all of these different tools and everything else, that's tough. Explaining why you're getting a high EOB, that's tough. Why you're having to charge me more for my insurance versus just paying the cash rate, it's tough. There's no real simple solution as to here's how healthcare works in a 6th grade format and everybody understand it.
No, because healthcare does not work in a 6th grade format.
No, it does not.
So the system is not designed for consumers. It's designed for systems, and people are not systems.
And people benefit greatly from the current system.
Not most people.
The people that set it up.
Yes.
The people that set it up
so
benefit greatly from it.
I think one of the challenges also is that facilities simply don't know what things cost. You know, you started out in a cash pay environment, so you had to know what things cost. But most facilities simply do not. You know, I made an appointment with my dermatologist the other day, and I said, well, I'm a cash pay patient. And it was a very nice woman who answered the phone. She said, could you hang on for just a second? And I said, sure. And she came back and she said, well, apparently it's $85. Okay.
Yeah.
She said, well, you'll have to pay that when you arrive. She was completely confused by that. And she was very nice. I mean, it's very nice practice. They do good work. They have nice staff, but she was completely confused. And then I got there and I paid, and then I left and they're like, well, we'll just send you a bill. I'm like, no, I just paid. They're like, you just paid? Yeah.
Just the receipt, please. Thanks.
Even to people that work in it, it's very confusing.
Oh, extremely. Yeah. We've had quite a few what we call patient access representatives that do the registration, come over from larger hospital systems. And whenever we run the cash model, they get extremely confused. Yes. Just like you said. Wait, I don't have to go here and get approval from my manager over there to authorize a cash payment? Oh, it's just listed right here? Like, wow, this is nice.
And nobody's going to yell at them?
No. It's like, it's amazing. We offer, you're just jogging my memory here. There's a program that we offer at our hospital system called our prompt pay discount. Because once again, we don't really know if your insurance, even though they're legally supposed to,
will
are going
not
to pay the bill at all, right? Or they're going to assign some funky little code that makes it all your responsibility. So kind of to avoid that, we offer what we call our prompt pay discount for patients that walk through the door at the emergency department. Depending on the level of visit, it could be $400 up to $1,200 between a level 1 and a level 5, right? If you move into observation, then we have a flat rate of $3,000. Majority of our cases are going to be in the $400 to $800 range.
Yep.
Because a lot of people use the emergency room inappropriately.
Yes, they do.
And we are frustrated of that as well, too.
Well, of course.
We don't want you to come in here for a hangnail. That's not a true emergency.
Yep.
We do want you to come in if you have shortness of breath, if you're having chest pains, if you're getting lightheaded and dizzy and about to faint. Those are true emergencies.
If your femur is sticking out your leg.
If there's an obvious laceration and you're profusely bleeding all over the lobby, please come back. Don't wait there to fill out the paperwork. But no, it's people have treated the emergency department for so long as their primary care provider. We saw a real opportunity because being the small system we are, if we identify a problem, we can implement a solution extremely quickly. About 4 or 5 years ago, we recognized that there was a huge shortage at the time of direct or primary care providers as a whole. Still is. We've seen the rise of direct primary care providers in the area, but not everyone is adopting to that model. We recognized that there was an opportunity to become more of a localized, small neighborhood type healthcare system, offering things beyond the emergency care, primary care, the labs, the imaging, the more outpatient type services, bringing in specialists to work in our facilities, things along that nature. We believed in that model so much that we wanted to actually develop a membership to our hospital system. For today, as an individual, you can have unlimited imaging, labs, primary care, and emergency care coverage for $1,200 a year. That's $100 a month.
That is remarkable.
That takes care of all of the costs behind the scenes of employing the providers, the nurses, the techs, the labs, all the wonderful property taxes we have to pay around here. Gotta love Texas. Woo! But in all seriousness, health care at a local level can be delivered at a cost-effective manner.
Yes.
Where I would encourage employers to do is to work with those local healthcare providers in that area. Start developing a real relationship, get involved with the local chapters of things like the Free Market Medical Association, where we already are banding together of the good providers that want to see change. Be involved as an employer, and you will find the right solutions in those kind of chapters.
And more solutions than you would think were possible. You know, we were just at an FMMA meeting, and there was primary care, secondary care, tertiary care, advisor community, and employers. I mean, you had the entire model in the room. You know, so it is possible today to do that.
And it's special when things happen like that too, because everybody gets to see the perspective of everyone else.
Yes.
And for so long in a broken out, disenfranchised type model of health insurance, the right hand usually doesn't know what the left
hand is doing.
Exactly. Exactly. So, and I'd like to kind of talk about our journey, if that's okay,
Please.
with as an employer of 140 full-time employees, 300 mix of part-time and PRNs. We started out at the time, through the evolution of our company, having a fully insured health plan.
How did you feel about doing that?
At the time, we were still learning how health insurance worked. And it was really interesting. The thing that taught us the most from a healthcare provider standpoint was being the employer. You just don't dig into that stuff until it directly affects you. And we started out in a fully insured model. We only had 35 full-time employees on that fully insured model. And we were looking at the price tag because we were getting ready to scale and bring on a lot of these different facilities, inherently growing in staff. At that current price tag, we were like, I don't know if we can do this.
Yep. And not only the price tag, but the lack that came with it.
Well, and we would request our claims data, and it was just...
No, you can't have it.
What do you mean we can't have it? Yep. And then if you force them to give you any sort of data, it only shows you the pretty little graphs. And you're like, okay, that really doesn't help me out with anything. Thank you.
Could you say that again?
It shows me the pretty little graphs.
That really don't help you.
That really don't help me out with anything other than this is how much of my money you spent. Great.
Yes.
Congratulations. Thank you. We started out in the fully insured model and quickly recognized that there was better alternatives out there. But it wasn't easy. You had to roll up your sleeves.
Yep.
Put on your big boy pants and figure out how to get it done, right?
Let me throw in there that what you did is a little easier to do now.
Yes, it's grown in popularity.
Yes. And the solutions, people talking to each other and the solutions are better. But what you did was hard.
At the time,
yes.
5-6 years ago now, we moved from the fully insured model and we kind of tiptoed into a level funded health plan. We had some really smart people around us that had been in the industry for quite some time that were advising us, hey, we should do this, this, and this. And we got back the renewals from our fully insured plan and stacked that up against these new proposals. Well, yeah, I'm going to take the 30 to 40% savings on this model of the level funded as opposed to thank you, big insurance carrier, but no thank you.
Yep.
We, learning at the time, moved into a fully reference-based pricing model.
How do you do with your employees in that model?
It was trial by fire. Because yours truly over here was saying, oh, this is going to be the best thing ever. We're going to have so much savings. Our employees are going to love it. They're going to have such low premiums. Which was all true. But no one really kind of held my hand through the reference-based pricing mess at the time.
Yes.
We'd also kind of grown out of state at this point where we were in Nebraska and 2 different markets. We were familiar with Austin, not so familiar with Nebraska.
Yep.
Come to find out, Nebraska is a big no state for reference-based pricing. A lot of the hospitals banded together and said, we are not going to take it.
Yep.
So that left me in a situation with several of my employees where we were having to duke it out with those larger hospital systems, and sometimes they wouldn't budge on the price.
Yep.
So once things like that started happening, we had a bad health insurance plan.
Yes.
And they wanted a logo because it made them feel safe.
And comfortable.
And then their provider and the registration isn't giving them, well, we've never heard of this insurance before.
This is bad. We've never heard of this.
This can't be good insurance.
Yes, I've never heard that before.
So we dealt with that with our employees, moved into the year after that, taking the feedback from them, moved into a Aetna network, but we'd made a switch on the back end from the level funded to a captive at that time called BevCap.
Okay.
Where with the help of a couple of advisors, we were able to get into that program, started learning how the captive really worked as a unit with all of the other employers kind of banding together to share in that risk. And from the employee friction standpoint, we had very little to none because we had the network associated with it.
Yep.
But then on the financials,
you took a hit.
We took a hit.
I'm going to stop you there for just 1 second, and I'm going to explain for people that don't always understand the journey there. So fully insured means that you transfer all of your risk to an insurance carrier, typically a Blue Cross, a Cigna, United, Network. In the industry, we call those the BUCAs. Level self-funding is when you partially self-fund your claims. So you can see your buckets. You can see your administrative bucket. You can see your claims bucket. and you can see your reinsurance bucket. Because even if you're fully insured, you have those buckets. They just benefit the carrier and not you. So you can see those buckets. You pay your maximum claims liability for the year, and then you retain, depending on the program you're in, 50 or 100% of the unspent claims dollars. Technically, you are self-funded, but you are protected. Your finance mechanism doesn't look like self-funding. You're paying a fixed premium for every employee every month. And for a smaller employer, that really is it's a more manageable, it's a cash flow management issue. So you're going to pay the maximum. And then if there's any unspent dollars, and 6 years out of 7 there will be, you'll get those back. They don't stay with somebody else. Self-funded, pay as you go, just means you have the same 3 buckets. You have an administrative bucket, a reinsurance bucket, and a claims bucket, but you pay the claims as you go. You still know what the maximum is, but you're paying your claims on a weekly basis. A captive means you're self-funded. You have banded together with a group of other like-minded employers. You've pooled your money, and you still have reinsurance. And if there's profit in the captive at the end of the year, it comes back. And if there's not, there's not.
Right.
So, okay. So you're in the captive. You take a financial hit because no reference-based pricing.
So we moved from reference-based pricing to a network contract. And going back to our earlier conversation, it benefits the insurance companies to keep the cost of healthcare high.
Yep.
Because then they can justify charging you more on the premium.
Mm-hmm. And they can say they had the best discounts.
And they have the best discounts.
A discount is a made-up number on a charge master, which is a made-up number.
Exactly. It means nothing.
Yep.
So we went from maybe 160% of Medicare claims to upwards of about 240%.
That would be really normal.
When you moved into those network contracts. And when you talk about $100,000, let's call it knee replacement, there's a big difference between 160 and 240.
Yes, there is.
And when you have the severity and the frequency of claims that pile up, that can easily get you to $1 million or more in the medical spend pretty quick.
Absolutely. National average, the Milliman national average is a little over almost $16,000 now. In Texas, I would say that's a little high. Texas high is 10 or 11. And if you're at 15, then really you're on fire. Yeah. But 10 or 11 is kind of the average that we see in Texas. You know, depending on the industry, might be a little higher or lower. But for 100 employees, $10,000 an employee, that's $1 million. Yeah. It's not hard to do that at 240.
No. And so where's that balance, right? Because you want your employees to feel like they have a good health plan.
Yep.
You want to do the financial thing that's right for the company because you don't want to just spend more money on their health insurance premiums for no reason.
Yep.
I would rather give my good employees a raise.
Imagine that.
You know? Why can't my employer give me a raise? Well, every year, 30 or 40% of my increase is on the second most expensive line item after my wages, which is my health insurance.
I have a client that their employee premium has now been the same for 4 years, but we cut it by 25%. There was applause for the CEO, who is an introvert and was really not very thrilled by this, but applause. I mean, and that was the first year that they had gotten their merit increases about 2 months before, and they were not clawed back by a health insurance increase. It was, and they have done a remarkable job of keeping their costs in check and flat. And we've been doing some good things, but we do that because we control the cost of some of their things.
Right.
You know, not everything. We don't do everything I want, but we do some things.
And there's incentive, right? At the end of the day, you're looking at that analytical data. It's not just a financial incentive, but an overall health and well-being of your employees.
Yes.
That, hey, maybe we can get those A1C levels a little lower. Hey, you know, we have this really cool weight loss program that we offer. would you be interested in participating in? It's going to cost $0 for you. Or we have this really cool insulin kit that we can get to you at no cost.
Or we've ramped up our mental health, our behavioral health program, because I don't have a client that is not having a mental health issue in their workplace. I'm sure you don't either.
Oh, no, I don't. Not at all.
No.
That doesn't exist. At least we don't talk about it, right?
But I mean, it's a problem. You know, when the manufacturers come to you and say we have a mental health problem, we seriously are having a challenge.
There's a lot of things we could talk about today.
Yes.
Going through all of these different evolutions of the health plan and operating them and eventually ending up where we are today and are captive with BevCap. We took a different approach, but kind of a 50-50 in the sense of we used somewhat of a network, but it's more of a localized network with much lower rates negotiated with the hospital systems. And for those in Nebraska, we don't have that localized network option there. So we did have to lean on a PPO.
And sometimes you just have to do that for now.
But majority of our employee base is here. So we can see in the recent claims and everything else that there is a trend downward as far as medical spend as opposed to last year, which is good. Employees are still accessing healthcare like they normally were last year with the ease of access of having a logo. Yep. But ultimately, we would like to get back to the reference-based pricing model, but we're just not going to jump fully into it until we ease our employees into it step by step.
Is that the most valuable lesson you learned over the course of this, is that you really have to help your employees understand what it is that you've done? That the communication, I guess, is the key piece.
It is. It absolutely is, because going back to our earlier conversation, most employees are spending 30 to 60 minutes reviewing their health insurance a year.
If you're lucky.
If you're lucky, right? Or they're just going through and picking whichever one is
cheapest, most expensive. Yeah.
And it's that ongoing education and getting the buy-in from HR too, because there's two ways that HR can look at a self-funded health plan. Oh my gosh, that's a lot of work. Yep. You're asking me to do what? And I have to do that every week or every month? I don't know if I think this is a good idea. But on the flip side, once you get their buy-in and they start recognizing, we're able to reduce those premium costs year over year, or, hey, we're able to get employee A and B the healthcare they need at an affordable rate. And they're not all of a sudden coming to me with a problem that I don't have a solution for.
And I think that's one of the most underrated virtues of a self-funded plan, is that you can, there are some things you can't do, but you can do just about anything in a self-funded plan that you want to do. You can't discriminate, and it can't be illegal. Right. That's pretty much it. Other than that, you can do anything you want. Yep. And you can build a plan that works for your population and good conversations. But you need buy-in from HR. You need buy-in from the executive leadership that we're doing this because we want you to have access to healthcare. It's not because we're trying to cheap out, right? Because that is what people think, right?
Absolutely.
So aside from the communication, what would you like other employers to understand about cash pay, self-funding, things that you've done both from a business perspective and as an employer with people that depend on you?
I'll say the first thing is don't go from one end of the spectrum being
to the other
to the other right off the bat. I know it looks great financially on paper, but you are going to have some struggle with your HR and your employees at that point. Start picking out things that you can chip off year by year, right? Moving into a level funded health plan. Yep. Getting the idea of funding those accounts, right? Understanding with your benefits advisor all the different minutia of where your dollar is going. Yep. And why is it like that? Or what is max funding? What does that mean? Can you tell me, please? There's a whole lot of terminology that you are going to have to adapt. especially if you're not already in the healthcare industry, you're going to start hearing things like reference-based pricing. Well, what does that mean? Well, I'm referencing the Medicare rate.
Yep.
Or I'm referencing fair market health. There's a lot of different tools out there that allow us to kind of pinpoint the price of healthcare. Now it's cash, right? And you can kind of compare your cash rate to your insured rates or your contractually agreed upon insured rates, or you can compare it to the Medicare rates. As an employer, I think the best thing you can do, once again, is just align yourself with providers that are willing to change and think differently. If your healthcare provider is incentivizing you to do Blue Cross Blue Shield again because they're getting the highest reimbursement, that might not be the best healthcare provider for you to work with. If you are an employer that really cares about your people and wants to see a long-term company grow, flourish, and build a great reputation, I don't believe you can stay in the fully insured model for much longer. If you're a company that can handle 20 to 30% renewals year over year, you must be very cash rich.
Yep.
Because that was not our company. If we would have stayed on that same trajectory and not done anything about it, I don't think we could even afford to meet the minimum payment that is required for having a health insurance policy for our employees.
I understand. It's a big nut.
If you told me 5 years ago that I was going to have 150% of what I was paying then to now,
you couldn't do it.
We just financially could not do it. You're going to have a rough first 1 or 2 years moving into a level funded or a self-funded plan because of the terminology, because you're learning while you're also trying to educate. You're learning while you're trying to educate your employees. That
I'm going to
struggle.
Throw something in there.
Yes.
So I think that it is the responsibility of the advisor to provide a fair amount of support there and to field the communication. And I'll criticize my own community and say that many do not have a full understanding themselves and therefore cannot communicate what has just happened. I've also seen where there are a lot of producers who fully understand level funding, self-funding, captive, single parent captive, you name it. And all the tools, right? Reference-based pricing, direct contracting, bundled surgeries, cash pay pricing, but they don't train their staff. And the work falls to the staff. So unless you have a well-educated advisor team, it's going to be harder.
Right.
You know, a solid advisor team can pick up that and educate quickly and answer quickly and help people get where they need to go.
I'll piggyback off of that a little bit because we've had a couple of different advisors with our hospital system for some time, and necessarily bigger isn't always better.
Thank you.
I'll say that
and
again.
I didn't pay him to say that.
I'll say that again. Bigger isn't always better. Because when you start getting behind the scenes and you start realizing where some alliances really truly are, there's no incentive for them to help reduce your cost.
Correct.
That's their paycheck. You know, if you got a 10% increase, they got a 10% raise. So sometimes you really have to look at who your advising team is and where their incentives are. Because ultimately, if it's against my own, how can I expect you to be on my team and helping me bring down these costs?
I think it's an important question to ask. And I ask it all the time. But that's my business, right? So, and then they're like, well, you're just saying. Well, no, I'm not really. So, and I know some of the folks you've worked with, and you do have some really excellent advisors. And you're very lucky to have found them.
We appreciate that. And we are lucky to have them because without having someone else to guide us through this mess of healthcare, I mean, even being in healthcare industry, we don't know anything about health insurance.
But I think here's the thing is as an industry, we have done such a good job of convincing people that health insurance is health care.
Yes.
And I'm sorry, it is not. Healthcare is what you do. Risk financing is what we do.
Exactly.
They're two very different things.
Immensely, yes.
Very, very different things. And, it's not the same. And Blue Cross is not providing any of your healthcare. Neither is Cigna, and neither is Aetna, and neither is Blue Cross and Humana while they're still at it. They're not. They are financing your risk.
Yes.
And it is their job to make a profit.
That's exactly
And it is
right.
your job to make a profit for your business as well.
Correct.
And you're just very clear about it.
We don't need to have multi-billion-dollar buildings downtown.
Are you sure?
That are write-offs for us. No. No, we don't.
What is your best piece of advice for somebody who understands they have a problem? And we talk to employers all the time that they understand they have a problem. They just don't know how to fix it.
Bunker down. Find good people that understand the real issues of healthcare and how to fix them. But dedicate your time and energy to actually learning the problems, because someone can present you the solution, but if you don't know what the true problem is, you don't really recognize that as a great solution.
Yes.
So spend time with your employees. Ask them, what was their last visit to the doctor like? What was the feedback that employee gave to you, and how could you go back and make the program better? Ultimately, we have a very vocal company.
I'm sure you do.
If they don't like something, they're not afraid to stand up and talk. So I did get a trial by fire the first year that I switched from a fully insured to the reference-based pricing. And I tried to educate at the same time while I was learning it.
It's hard to do.
It's hard to do both, right? You really need to dedicate your time to educate and then teach, but you also need to have benefit advisors that are saying the same message, and HR that's saying the same message. And your executives are on the same plan, doing the same things that you are.
Yes.
Mr. or Mrs. Employee.
That may be the key, is that the executive teams need to be using the same strategies as regular staff.
Absolutely.
And then everybody's in the same boat, and that's okay for them, so it's okay for me too.
So yeah, my biggest advice would be just education. It's sit down with your broker more than once a year.
Yes.
Have ongoing quarterly check-ins, right? Quarterly check-ins, evaluate your plan, get familiar with the analytics that you're now going to be receiving if you move into a self-funded or level-funded type plan, because you can get down to the penny of where everything is going.
Yes.
And if you ask that of your commercially insured health plan, you will not get anything near that information.
Correct.
So it will be a mind shift. You will think a little bit differently about healthcare and ways that you can incentivize with programs by removing copays, deductibles, and co-insurance. You have the carrot and the stick model, right? Mm-hmm. You reward employees for doing good behavior. You don't punish, but there is what already is in existence of deductibles and copays and co-insurance if they fall outside of that model and don't want to adhere to the carrot that you've given them.
We build them that way as well. And we found that it is better to not force people into your model, but incent them into your model. Let employees have a good experience in that model, and then let that grow. And then for somebody that, maybe they have a long-standing relationship with a provider and they're just not going to give it up.
Yeah.
And it's a provider that maybe doesn't meet the specifics that you would like. Okay, they're not going to get the benefit of zero copay, zero out of pocket, but there's still coverage there when something happens.
Yes.
And what if there's an emergency? You have to allow people some flexibility.
Yes. But an incentive could also look like you have $5,000 deductible.
And zero over here.
At zero over here. Yep. For something that's non-emergent, maybe it's a surgery of a knee replacement or something.
Correct.
Right? And what that does for the employer is, well, how is that going to save the plan any money if you're giving it to them for free and paying it at 100%? Well, Mr. Employer, we did a cost analysis between provider A and facility A and provider B and facility B. Provider B over here is about $20,000 or $30,000 cheaper for the same exact surgery, same exact surgeon, just a different facility and different location.
We have a client who we had somebody that had a back surgery, and we'll leave the opinion about back surgeries off the table. But the bill charges were $80,000. The PPO discount ended up being in the 30s. The RBP price was $10,500.
Was that an ACDF or no?
$10,500. There is, and the plan was an RBP plan. We've modified the plan somewhat, and there is a direct contract at the same facility for $11,500. Direct contracts are a little bit easier than RBP.
Yes. And
I would have taken that contract without any headache at all. But that is amazing to employers. They're like, what do you mean?
You're magic. You were magic, however you did that.
And it's not hard to do.
No.
It's not hard at all.
It really, putting my employer hat back on, what we've always struggled with as a operational entity is the cash flow. Because of us being out of network, because there is no guaranteed reimbursements, and going back to we have to bill crazy high prices to maybe get a 20 to 18% reimbursement on those billed charges, we will take cash all day long because, like every other business owner, we have overhead. We have employees we have to pay. We have the rent we have to make. I mean, we have electricity. We got to keep the water running. There's a huge incentive on both sides to not us carry the crazy high accounts receivable over the course of a year and a half and end up writing most of it off because we were never going to see it ever.
Anyway.
Yeah. And then the other side is the consumer of the healthcare that isn't having to see that $20,000 ER bill and all of a sudden is at a reasonable rate of $400 to $1,200. I think it's a better system overall for everybody, except for maybe a handful
of entities.
Yes,
I would agree wholeheartedly, and I think we will leave it there today. Yeah. Thank you very much. I think this was really helpful to people.
Well, thank you for having me, Allison. I appreciate it.
Absolutely.
We hope you've enjoyed this episode. Raising the Bar is powered by Altique Consulting, the country's leading independent expert in healthcare cost containment. Astute employers know there's a better way to offer health insurance, and we help them achieve it.